What is this disease, students? There is abnormal accumulation of fluid within the pleural space. This phenomena is called as pleural effusion. Already we have discussed the clinical signs in pleural effusion. It is a pushing lesion. Then if you percuss, there will be stony dull note. And what else you can see on a chest X-ray? There can be whitish area with meniscoid fluid level with mediastinal shift. Now let us discuss how to approach to pleural effusion. Whenever they give you any pleural fluid analysis, how to come to a diagnosis. So for approach to pleural effusion, most important thing that you should know is Leit's criteria. So this pleural effusion based on Leit's criteria, pleural effusion based on Leit's criteria, we can classify the pleural effusion into two types. We have a transudative pleural effusion and other is an exudative pleural effusion. We have a transudative pleural effusion and other is an exudative pleural effusion. Now when do you call it as a transudative pleural effusion? When pleural effusion protein by serum protein, pleural effusion protein by serum protein is less than 0.5 and pleural effusion LDH by serum LDH is less than 0.6. So in terms of decimals it is 0.6, in terms of fraction 2/3. Pleural LDH is less than 2/3 of serum LDH. So it means whenever the protein ratio is less in the fluid, LDH ratio is less, it is considered as transudative pleural effusion. When do you call it as exudative pleural effusion? Any one of the following, either protein ratio is more or LDH ratio is more. Either protein ratio is more or LDH ratio is more, you should call it as exudative pleural effusion. Now if it is transudate, life is very easy because majority will be systemic causes. So the most important system is your cardiac system. So your cardiac system, and when it involves, there can be cardiac failure responsible for pleural effusion. Cardiac failure responsible for pleural effusion. Right now cardiac failure is considered as most common cause of pleural effusion worldwide. Cardiac failure is the most common cause of pleural effusion worldwide. Cardiac failure is the most common cause of pleural effusion worldwide, students. The next important system can be kidney. Involvement of kidney will cause nephrotic syndrome. Then the third important system is your liver. If liver disease is responsible for pleural effusion, this phenomena is called as hepatic hydrothorax. Liver disease responsible for pleural effusion, this phenomena is called as hepatic hydrothorax. Next, we have a procedure called as peritoneal dialysis. And finally, hypothyroidism. Hypothyroidism will cause pleural effusion. Hypothyroidism, and exact mechanism is not known. It causes pleural effusion, but mechanism is not clear. Mechanism is unclear. Now let us discuss the common transudative effusions. Coming to cardiac failure. Now tell me, students, for fluid to accumulate anywhere, what are the pressures that should be modified? Either increased hydrostatic pressure or decreased oncotic pressure. In cardiac failure, the reason is increased hydrostatic pressure. In cardiac failure, the reason is increased hydrostatic pressure. Now, what is the reason in nephrotic syndrome? In nephrotic syndrome, there will be massive proteinuria. The reason for pleural effusion is decreased oncotic pressure. This is your simple pathology, students. You have understood in your second year. For accumulation of fluid anywhere, the important causes are either increased hydrostatic pressure or decreased oncotic pressure. So, same thing is happening in cardiac failure, nephrotic syndrome, responsible for pleural collection. Then why in hepatic hydrothorax? Now, first of all, let us see what is hepatic hydrothorax, the mechanism. See, whenever there is a liver disease, the ultimate result is ascites. Now, when there is ascites, there can be increased intra-abdominal pressure. Normally, your diaphragm will be having tiny holes which will not open in equilibrium. Whenever there is increased intra-abdominal pressure, these tiny diaphragmatic holes can open. Now, once the diaphragmatic holes are opening, from the abdominal cavity through the diaphragmatic pores, the fluid can come into the pleura. So, the mechanism of hepatic hydrothorax is liver disease will cause ascites. Ascites will build the intra-abdominal pressure. When the intra-abdominal pressure increases, there will be opening up of diaphragmatic pores and the fluid will be transferred from the abdominal cavity into the pleural cavity through those diaphragmatic pores. So, write down in hepatic hydrothorax. In hepatic hydrothorax, the mechanism is transfer of fluid into pleura through diaphragmatic pores, transfer of fluid into pleura through diaphragmatic pores. Now, what is peritoneal dialysis? You must be knowing dialysis is of two types. If you are using blood, it is called as hemodialysis. So, when you use peritoneum, so you are putting a catheter in the peritoneum and you are putting a catheter in the peritoneum and you are infusing some concentrated solution. So, this phenomena is called as peritoneal dialysis. So, whenever you infuse more and more fluid within the abdomen, the amount of fluid increases. It can increase the intra-abdominal pressure. Once the intra-abdominal pressure increases, the diaphragmatic pores can open and that can facilitate fluid entry into the pleural cavity. So, for hepatic hydrothorax and peritoneal dialysis, the mechanism is the same, transfer of fluid through the diaphragmatic pores. This is regarding transudative pleural effusion. Now, if it is exudative, your life becomes very difficult because you need to evaluate. So, what are the tests that you need to send further in exudative pleural effusion? First thing, you should look for cytology. You should send it for cytology. So, why for cytology? Whenever you want to see whether there is any malignancy, you can send it for cell count to see exactly what is the cell type of cell getting elevated. So, we go for cytology, we go for cell count, we go for cytology, we go for cell count. The next important thing is you should send it for gram staining. So, why gram staining? Gram staining to look for any infection. You should send the fluid for gram staining to look for any infection, So, then next important thing is you should send it for TB markers. What are the important TB markers? Now coming to TB markers. Why I should send for TB markers is TB is considered as most common cause of exudative pleural effusion. It is considered as most common cause of exudative pleural effusion worldwide. What are the TB markers? TB pleural effusion is generally lymphocyte predominant. It will be lymphocyte predominant. There will be increased ADA. ADA means adenosine deaminase. Increased ADA. ADA will be more than 40 international units, and interferon gamma will be more than 140 picograms per ml. So the point to be noted here is, whenever there is TB happening in your body, there will be some substances released in your body. One such substance is ADA and other is interferon gamma. So if the fluid contains more ADA and interferon gamma, what does it mean? There is chances of TB. Apart from this, next important what we should send is, you should know what are the causes of low glucose pleural effusion. Low glucose pleural effusion in the sense pleural effusion glucose less than 60 mg%. Pleural effusion glucose less than 60 mg%. What are the conditions? It can be seen in empyema. It can be seen in malignancy. It can be seen in rheumatoid arthritis. Now what is the reason for these pleural effusions to have low glucose? Now what is meant by empyema? Empyema means pus. What does pus contain? Actively dividing bacteria. What do bacteria consume as food? Glucose. Then malignancy. What will malignant pleural effusion contain? Actively dividing tumor cells. What do they consume? Again glucose. In rheumatoid arthritis, just like arthritis, as a part of systemic involvement, there will be pleuritis, and this pleuritis will be responsible for pleural effusion, and these inflamed pleural cells can have high metabolism, and fuel for that metabolism is again glucose. Let it be empyema, malignancy or rheumatoid arthritis, ultimately the glucose is getting consumed, so they will have low glucose pleural effusion. Then what are the causes of high amylase pleural effusions? High amylase pleural effusions. These can be seen in pancreatitis, esophageal rupture, pancreatitis, esophageal rupture, and malignancy. Now what is the reason for pleural effusion here and why it is high amylase? So first we will see pancreatitis. Now you know that your pancreas is an infradiaphragmatic structure. Whenever your pancreas are getting inflamed, it can irritate the diaphragm. So whenever the diaphragm is getting irritated, the diaphragmatic pores can open. Through these diaphragmatic pores, pancreatic rich inflammatory fluid is coming into the pleural cavity. And what does pancreatic inflammatory fluid contain? Amylase. Then why in esophageal rupture there is pleural effusion? Your esophagus is a mediastinal structure, and adjacent to the esophagus there is mediastinal pleura. Whenever there is damage to esophagus, in that force the adjacent mediastinal pleura can also be damaged. So the contents from the esophagus will now go into pleural space. And what does esophagus contain? Saliva. And what is saliva rich in? Amylase. Saliva is rich in amylase, that will be seen in the pleural fluid. And in malignancy, few tumor cells, they themselves can produce amylase. Because of that, within the pleural effusion there can be elevated amylase. So very important table, students, differentiating transudates and exudates for your exam. So whenever they give you any pleural effusion, by seeing the Light's criteria, know whether it is transudate or exudate. If it is transudate, see possibility of a heart disease, kidney disease, liver disease. If it is exudate, you need to send various investigations, cytology, cell count, gram staining, TB markers, low glucose pleural effusions, high amylase pleural effusion. By going through all these investigations, you can come to the diagnosis. So once you treat the diagnosis, this pleural effusion can also be managed ultimately. So this is the algorithm. This is the algorithm to approach to pleural effusion. Now let us see other important exudative pleural effusions. We have high lipid pleural effusion, white colored pleural effusion. Two types. One is chylothorax and other is pseudochylothorax. Chylothorax, pseudochylothorax. This chylothorax is accumulation of chyle. It is accumulation of chyle due to rupture of thoracic duct. Accumulation of chyle due to rupture of thoracic duct. Most common cause will be surgical trauma. Most common cause will be surgical trauma. Next, malignancy. Pleural effusion triglycerides. Pleural effusion triglycerides in this will be more than 110 mg%. Now let us see the mechanism of chylothorax. You must be knowing your thoracic duct is a structure which carries chyle in your body, and thoracic duct is also a mediastinal structure. So whenever the thoracic duct is damaged, adjacent to that there will be mediastinal pleura. So this mediastinal pleura can also be damaged. Because of that, the thoracic duct contents can go into the pleural space. Because there is thoracic duct content called as chyle going into pleural space, this phenomena is called as chylothorax. And what is the most important cause? Surgical trauma. Whenever you are doing some chest surgery, accidentally thoracic duct might be damaged. Adjacent pleural membrane can also be damaged, resulting in leak into the pleural cavity. Malignancies. Few malignancies can directly infiltrate the thoracic duct, damage the thoracic duct, resulting in chylothorax. And what does chyle contain? Triglycerides. That's why within the pleural fluid, triglycerides will be high. Coming to pseudochylothorax, this is accumulation of cholesterol crystals. Accumulation of cholesterol crystals in long-standing effusion. In long-standing effusions. Usual long-standing effusions are due to tuberculosis, rheumatoid arthritis. Tubercular effusions and rheumatoid arthritis effusions are generally chronic effusions. And here pleural effusion cholesterol will be more than 200 mg%. Pleural effusion cholesterol will be more than 200 mg%. Now what is this pseudochylothorax? What exactly happens here is, now whenever there is a long standing effusion for months together, gradually all these cells accumulated in that pleural effusion will die. So they will get degenerated. Whenever these aged cells break, from those cells cholesterol will start accumulating in the effusion. So the source of the cholesterol is nothing but those aged cells. So once the aged cells degenerate, once they break down, there will be release of cholesterol into the effusion. It happens in tuberculosis, rheumatoid arthritis. Because there is cholesterol getting accumulated, pleural effusion cholesterol will be more than 200 mg%. So if they ask you, in chylothorax, what is the lipid elevated? Your answer should be triglycerides. Your answer should be triglycerides. In pseudokylothorax, what is the lipid elevated? Your answer should be cholesterol. Because they are lipids, the color of the effusion will be white. Both are white colored pleural effusion. So what is the lipid elevated in chylothorax? It is triglyceride. What is the lipid elevated in pseudokylothorax? It is cholesterol. Next important exudative effusion is a paranimonic effusion. It is a paranimonic effusion. The definition of paranimonic effusion is effusion associated with pneumonia or bronchiectasis or lung abscess. It means whenever there is an infective manifestation, if it is causing an effusion, it is called paranimonic effusion. Patient's clinical features will be fever, shortness of breath, chest pain. Now generally, when there is a paranimonic effusion, if you treat the underlying infection, that effusion will also resolve automatically. But there are few situations where you should immediately put an intercostal drain and completely remove the fluid. Indications for active intervention in paranimonic effusion. What is that active intervention? It is nothing but intercostal drainage, ICD. So when you should immediately remove the fluid? 1. When there is pus. Pus anywhere should be immediately drained. So why especially in pleural cavity? What is the adjacent compartment to pleural cavity? It is mediastinum. Pus is a huge source of infection. If that infection goes into mediastinum, sepsis can develop very rapidly. Then pleural effusion pH less than 7.2. Pleural effusion glucose less than 60 mg%. Presence of loculations. You have seen ultrasound of the chest. Now the fluid is becoming septated. So there are some small septa formation. So that is called as loculated pleural effusion. Now whenever you see any of these three, it means there is some active inflammation. There is some active inflammation due to some active infection. These three indicates that there is some active inflammation due to active infection. Active infection in the pleural space should be immediately drained, because if it goes into mediastinum, that infection, sepsis can develop rapidly. Then pleural effusion gram staining. You have seen it under the microscope. It itself shows there are microorganisms. It means the pleural fluid is actively infected. You should immediately remove it. These are the indications where you might need to completely remove the fluid. Generally, if there is a paranimonic effusion, if you treat the underlying infection, it is sufficient. But there are few situations where you should immediately put an ICD. Now let us see a clinical scenario. There was a 45-year-old male patient. He presented to you with these symptoms: fever, shortness of breath, chest pain, and you have taken a chest X-ray. Chest X-ray was showing features of pneumonia. Chest X-ray was showing features of pneumonia and pleural effusion. There is both pneumonia and pleural effusion. Now what will be your diagnosis? Your diagnosis will be paranimonic effusion. So what you have seen here, a 45-year-old male, he has come with these features. Chest X-ray was showing pneumonia and effusion. Now what will be your diagnosis? Paranimonic effusion. Now the same case came to me. I wanted to know the consistency of the fluid. So I put a needle. And started to aspirate. This was the consistency of the fluid. When I aspirated, this was the consistency of the fluid. Now what will be your diagnosis, students? What will be your diagnosis? and what should be the next step in treatment. Now this is brownish colored fluid called as pus. Pus in pleural cavity is called as empyema. Next step, you should completely remove the fluid by putting an intercostal drain. They can give you a clinical scenario like this also, students. If it is empyema, you should immediately put a tube and completely drain the fluid. Then coming to malignant pleural effusion. This malignant pleural effusion can happen either due to primary tumors of pleura, or as a result of metastasis from other organs. Either primary tumors of pleura or as a result of metastasis from other organs. Now coming to management of malignant pleural effusion. The biggest problem is recurrence. Recurrence is very common. Even if you aspirate today, after few days again the pleural fluid will reaccumulate. Now how to manage the pleural effusions? First thing what you should know, recurrence is very common, but still the initial step will be you try to do a therapeutic thoracentesis. So first we do, so write down the stepwise treatment or management. You do a therapeutic thoracentesis done. If it is not reaccumulating, so life is happy, you can just stop there. But in majority, there will be reaccumulation. So if there is recurrence, what you should do next? You should insert an ICD. What is meant by ICD? Intercostal drain. You should insert an intercostal drain. Now for example, let this be the healthy lung. Around it is the pleura. Let this be the diseased lung. So because of this malignant disease, there is accumulation of fluid within the pleural cavity. If there is recurrence, I am going to put an intercostal drain. Now after that, once the lung expands and fluid is drained, what to do next? See here. Then this will be the situation now. This was the healthy lung. It will be like that only. Now in the diseased lung, what has happened? The lung has expanded. Because you have put a tube, the fluid has drained, and this will be the covering pleural membrane, and there was an ICD inside. Once lung expands and fluid is drained, now what you should do is into this tube you can inject sclerosing agent. So what are the sclerosing agents? We have talc, or you can add doxycycline. So we going to inject sclerosing agent. This sclerosing agent will go into the pleural space, and it functions just like an adhesive. It functions just like a gum, and it will fuse the pleural membranes together. So once the pleural membranes are fused together, there will be no space for fluid to reaccumulate. Inject sclerosing agents such as talc or doxycycline to obliterate pleural space. What is this phenomena called as pleurodiscs? What is this phenomena called as pleurodiscs? Now you can get a valid doubt. I am obliterating the pleural space. There might be some difficulty with respiratory mechanics. Point you need to know here is, whenever a patient reaches to you with malignant pleural effusion, already it is stage 4 disease. The life expectancy is only few months. In this last few months, instead of asking him daily to come to your clinic and remove the fluid by inserting a needle, this will be a temporary solution. Initially there might be some problem. See, whenever the other lung is functioning well, and after few days this lung will also adjust, and ultimately there will be some benefit to the patient. See, what we are doing is not a definitive method. We are not getting rid of the malignancy. We are just giving a palliative temporary measure so that the last few days of life will be bit less problematic to this patient. So this is called as pleurodiscs. But the problem with putting an ICD and doing pleurodiscs is, in few patients the lung may not expand early. So as long as that big tube is in place, patient will be having severe pain. As long as the tube is in place, there will be chances of infection going through that tube. So whenever there is some delayed recovery patients, whenever you suspect that there can be a delayed recovery in these patients, nowadays instead of ICD, we are putting a small flexible tube. So this small flexible tube is called as indwelling pleural catheter. You can see here a small flexible tube. This is small flexible silicone tube called as indwelling pleural catheter, also called as Pleurex catheter, also called as Pleurex catheter. Now the advantage of this is, patient will have less pain, less chances of infection, frequent drainage, and many studies have shown this was well tolerated, and also many patients experience this is well tolerated. So the conventional method is putting an ICD and pleurodiscs. The recent is indwelling pleural catheter. Indwelling pleural catheter, also called as Pleurex catheter. Indwelling pleural catheter, also called as Pleurex catheter. And in few institutes what we do is, in the first instance itself, whenever the patient has come to you with pleural effusion, you can also go for thoracoscopy. So you can do a surgery called as thoracoscopy. So thoracoscopic drainage of pleural fluid. So what you do is, instead of putting a tube, you put a device called as thoracoscope, and you are going to suck out all the fluid on the table itself, operating table itself. You are going to thoracoscopically do drainage of fluid and instill talc or doxycycline, and going to do pleurodiscs. But this is an advanced method, not available at all centers. But nowadays we can directly also do, if it is a higher center, instead of putting ICD and waiting for a few days, you can do a surgery. So surgery called as thoracoscopic drainage of pleural fluid, and doing pleurodiscs on that day itself, on the operating table itself. So this is a advanced procedure, not routinely done in all hospitals, but whereas putting an ICD and pleurodiscs can be done in all hospitals. Apart from that, there is another method called as indwelling pleural catheter, also called as Pleurex catheter. The advantage of this method is less pain, less chances of infection, frequent drainage, and it is well tolerated by the patient. So this is regarding pleural effusion. We have discussed what is transudate, what is exudate, what is chylothorax, what is pseudocylothorax, paramnemonic effusion, malignant pleural effusion.